I'd like to welcome everyone back, and I just have one small announcement. There was an iPad found in the room yesterday that has a white cover, so if anyone is missing their iPad, please let one of the staff know, and we will return it to you. For our next plenary session, our distinguished panel will discuss innovative care models, something that the Academy has taken pride in and done a lot of good work with the edge runners. But sometimes people beyond edge runners are also doing innovative things. To moderate this panel, we are joined by Deborah Toney. Dr. Toney is Director of Clinical Operations at Nevada Health Centers. She is the immediate past president of the National Black Nurses Association and is a Robert Wood Johnson Executive Nurse Fellow. Deborah?
Thank you, Joanne. Good morning. All of us are aware of the importance of innovation in our healthcare delivery system. These panelists will be sharing some amazing stories of transformation, which has resulted in significant improvement in access to quality healthcare. Each presenter will address the audience for 10 to 15 minutes, and then we will open the floor up for questions and answers. Let me begin by introducing our panel. Diane McGinnis practices in a frontier clinic that is moving toward being recognized as a patient-centered health home. She is the sole provider for an area with a 45-mile radius. Another nurse practitioner works for her company 45 miles away, and the closest physician is almost a 2-hour drive in distance. In addition to providing care in her clinic, Dr. McGinnis has used innovative marketing ideas to promote nurse practitioners as the provider of choice. She has been a nurse practitioner since 2008. And in addition to her clinic, is also involved in wilderness medicine education. Sandy Ryan is the first ever Chief Nurse Practitioner Officer in the industry and clinical advocate for Take Care Health Systems. If you go to a Walgreens Take Care clinic, you will likely see a nurse practitioner working under her direction. She was one of 6 founding officers of Take Care, taking the startup to the opening of more than 370 clinics. Ms. Ryan is also a founding member of the Convenient Care Association, the trade association for the industry. She leads efforts on legislative issues that prevent access to care, in addition to her clinical leadership role. She has received numerous awards and was the first nurse practitioner inducted into the Philadelphia College of Physicians. She earned her MSN from Arizona State University and is a fellow of the American Academy of Nurse Practitioners. Captain Caroline Oyama is a captain in the U.S. Public Health Service with over 30 years of public health and women's health experience. She is currently the senior consultant for women's health and the senior consultant for advanced practice registered nurses at the Department of Health and Human Services, Indian Health Service. Her work has led to an improved response to violence against women in Indian country, including the writing of the first Indian Health Service sexual assault response policy, establishing the standard of care for sexual assault care. These standards have resulted in establishment of policies for response to reports of sexual assault and improved care for the victims. Captain Oyama is currently involved in creating an Indian Health Service residency program to enhance APRN leadership opportunities with the agency. Please welcome these innovators of healthcare delivery systems.
Good morning. I'm Diane McGinnis, and I want to thank the Academy for asking me to share my experiences with you today. We were asked to speak about innovations in healthcare. I'll touch on the patient-centered medical health home and then tell you a story about my experiences at Frontier Health Clinic. As the conference has continued, I've been rewriting this presentation as other speakers have been covering some of the content. I want to thank Dr. Clancy yesterday for our keynote for covering the patient-centered medical home concept with you. So our colleague from ICN this morning talking about it's about the profession. And so I want to start with talking about the patient-centered medical home. And I want to start with, this is, if you notice, it says Transforming Healthcare Driving Policy. When we talk about what our colleague from ICN said about it's about the profession, in policy, every word matters. So personally, I don't like the term patient-centered medical home. I prefer it to be patient-centered health home. So as a professional nurse, I take umbrance with that title. Okay? So patient-centered, once you add the medical in, it creates all sorts of policy issues. And one that we've had happen for advanced practice nurses is that they're really pushing it to be a physician-led patient medical home. I say that whoever needs to lead it for that particular patient should be leading it. And in general, nurses are better leaders of an overall case management type of situation than a physician is. So that's mine on that. EPRNs are trained in both the medical and nursing models, so we have more of an understanding of what's going on. And we also have social work training, we have mental health training, we have a broad base of training. For those of you who aren't aware, I am from Nevada, and I just want to say that we're very excited. We are the 17th state to get statutory plenary authority for nurse practitioners. And that just started on July 1st, that we do not have to have a collaborating physician anymore. Does not mean we can't have one. We can still choose to collaborate with a physician if we care to. I prefer to just collaborate with whatever physician is out there. So I want to talk about being a nurse. And we have all these social networking sites. So I found this one and I thought it was quite interesting. Being a nurse means you'll never be bored. You'll always be frustrated. You'll be surrounded by challenges, so much to do in so little time. You'll carry immense responsibility, my tongue's twisting, and very little authority. You'll step into people's lives, and you will make a difference. Some will bless you, some will curse you. You'll see people at their worst and at their best. You'll never cease to be amazed at people's capacity for love, courage, and endurance. You'll see the life begin and end. You'll experience resounding triumphs and devastating failures. You'll cry a lot, you'll laugh a lot, but most importantly, you'll know what it is to be human and to be humane. So my title is Nurses Outside the Box and How to Get Outside the Box. So I just want to let you know there's not just one way to get outside the box, but since I'm up here, I get to talk about my way. So what I was thinking about with that title is this gorgeous map that you can see. See the little boxes down in the right corner? What do the boxes represent? They represent the population foci of my state, Nevada. The boxes are the big cities, the big towns. So to get outside the box, you have to go to the rest of the map. Okay, so we're talking about rural and frontier care. So to make, I'll be sharing I wanted to make this more scholarly, I guess, so I will be sharing the lived experience of advanced practice nurse in a frontier clinic to increase nursing knowledge. Okay? So to give you a quick graphic to put things in proportion, this is several northeastern states superimposed upon the state of Nevada. Okay, so those of you from here on the East Coast, if you recognize your state, you can see how large Nevada actually is. So I practice in Nye County. My corporation, Nevada Health Centers, has 16 clinics throughout the state. We serve underserved proportions. We're a federally qualified health clinic. We have several clinics that are in the large boxes, or the little boxes on the side of the map, if you want to say. And that's where we're serving our homeless population, our population that possibly doesn't have the income potential. But we also have several rural clinics. And in reality, most of our rural clinics are actually frontier clinics. The little pink thing in the middle of the map there that looks like it's an atomic bomb cloud, that's the county I practice in, Nye County. We have a population of about 43,000 people in that whole county. Now, if you remember the slide before, the whole state of Massachusetts fits inside that county. We have 43,000 people. But the bottom orange dot in that pink county is Pahrump. And Pahrump has 36,000 of those 43,000 people, which means the rest of that county has the remainder. It takes about 4 hours to drive from one end of the county to the other. So from Pahrump, the lowest orange, to where I'm at Beatty, which is the little middle orange section, it's about an hour and 10, hour and 15 minutes away, 75 miles. It's hour 10 because the speed limit's 70 the whole way, because there's no towns in between. From my little orange spot up to where you can see the two roads crossing is about almost 2 hours away. That's Tonopah. And then over, if you hang a let's see, it's to right for you guys. I had to make sure we're straight. Hang a right for you guys. Going out that orange line to the right, over there we have a Indian tribal clinic in Duckwater. But that's not part of our corporation, but just part of Nye County. So this is a quick map to show you frontier designated areas. Frontier and rural have different definitions depending on which source you're looking at. So for this National Center for Frontier, I can't see what it says, demographics in there, I believe. They've designated these green areas. You can see how large Alaska is. This map actually is in proportion. So Alaska is a huge, huge state, and you will hear from one of our other speakers, Captain Ioma, about Indian Health Services, and they help the Native Alaskans as well. But if you look at Nevada, since it's all about me, right? You see that Nevada is almost entirely green as well. So we're a very frontier state. So I want to talk to you a little about marketing, policy and politics and marketing. I venture that all of you have been the new kid on the block at one time or another. So in a small town, being the new person is a very newsworthy thing. My office manager's been in town for 30 years, and she still says that she's an outsider. So instead of Little House on the Prairie, I'm going to talk to you about Little Clinic on the Frontier. My story is not unique. As a new person in town, I've really used marketing in unique ways to promote myself, nurse practitioners, and to try to get people to the clinic for care. I'm caring for patients who have streets named for their families. Bear in mind, there's only like 15 streets in town. We have a population of just under 1,000. That's how they like to say it. Census says about 950. And so when you're in a small town like that, there's lots of ethical issues. Everybody meets in the lobby, if I'm running a little bit behind, and they're all talking about their medical care. So it's very hard to be HIPAA compliant. Really. It's very, very hard. I was a little bit late returning to my clinic from a personal physician appointment. My corporation, on their I always forget the terminology, Facebook page, there was a post that I was late for work within an hour and a half. Okay, just want to let you know that. So one of our people said, call the paper when you're doing interesting things. In a small town, the paper isn't needed. So another ethical issue. Because the town is so small, I basically know what street almost all my patients live on, kind of know what their homes look like. There's only about 10 stick-built homes. The rest of the homes are manufactured homes, trailers. Many people live in camper trailers. And I have a particular patient who's over 70 who lives in a camper trailer. So smaller than the size of this stage. And he wants a scooter. And he deserves one. Only problem is Medicare says that the scooter must be used inside the home. I know it won't fit in his home. So here's the ethical issue. If he goes and sees a provider for the VA, let's say, which is a 2-hour drive away, by the way, they're going to say, all right, yeah, you deserve a scooter. No problem, because they don't know what his home looks like. But I do. And so to be ethical, I had to tell him, I'm sorry, I can't get you your scooter. Because what he really wants it for is to drive around town to go get his mail. Our town is so small, we do not have mail delivery to each house. We have to go to the post office to mail all our letters. We have to go to the post office to pick up all our mail. So he really just wants it to go get his mail. And he really can't walk. And he can't drive. And he really deserves a scooter. And I had to tell him I'm sorry, ethically. However, if any of you guys are grant writers, if you want to write my patient a grant, I'll give you my contact information later, and I'd be really happy. So access to policymakers, that's always important with policies and politics. In a small town, it's kind of fun. I've had our local representative to the state Congress. He was driving through town. I was up at our state legislature talking about our APRN issues when we were waiting for our bill to pass. And I chatted with him a little bit, and I said, stop by anytime you're driving through town. Well, guess what? He did. So I don't know how many of you have just had your state legislature just drop into your clinic and say, hi, I'm here. But he did. And so we gave him a tour, talked to him about some of our issues, and wanted to make sure that he understood what it was like. I've also sat down with the county commissioner for dinner at Denny's. Sounds exciting. We have 2 restaurants in town. We have a Subway and a Denny's. And the Denny's is actually the casino restaurant, so you actually have to walk through the casino, through all the smoke and everything to get to Denny's. And we also have 4 bars in town, and each of them serves some bar food. We have a Mel's Diner that does breakfast and lunch, and I'm really excited for our veterans. The VFW has purchased a historic church that they're making their meeting hall, and so they announced at the town board meeting last week that they're getting their liquor license for their canteen. That really worries me as a healthcare provider with our veterans because there are substance abuse issues. They're so excited to have their own canteen to serve their liquor. So I'm going to talk a little bit about the home office in just a few minutes. And do they truly understand what's going on? So access to health care. As a federally qualified health center, we provide access to patients on a sliding fee scale. Looking at the demographics of our county, Nye County, remembering that 36,000 people live in one corner, the average age for our county is around 50. Okay? The average income, according to the Center of Statistics, is about $14,000 a year. Okay, so our clinic and my sister clinic, who's in Amargosa, who's, I said 45 miles away, we're both federally qualified health centers, and we both provide sliding fee scales. We also treat all Medicaid patients, Medicare patients, and basically anyone who walks in the door. So we are providing access to health care. But there's issues inside the access issues, such as lab results. I frequently look at my labs. They take about 24 hours to receive. I have to plan patient appointment times for when the lab courier is coming to make sure the blood is fresh. I've been known to personally carry tissue samples from skin biopsies down to Vegas with me on a Friday night in my car and drop them off at the lab. And so there's a lot of issues that we have to look at with a Frontier clinic of access to information, not just access to health care. Pharmacy access. The closest pharmacy, believe it or not, closest Walmart, is an hour-and-a-half drive away. There are no other pharmacies, so our company has worked with the state of Nevada. We have what's called a dispensing license. So what I'm able to do, I have about 40 generic medications in the clinic. And so I am able to dispense medications to patients. I don't have medical samples because guess what? The drug reps don't want to drive 2 hours to come visit me. Imagine that, one way. So they'd make a 4-hour round trip just to come see me. Wouldn't that be great? So basically we do have those medications also available on a sliding scale for the patients that have restricted incomes. Redundant supplies. Well, this is something that, remember the home office and do they understand? So there's a budget issue going on right now at my clinic, and we're being told that we should share a case of toilet paper with our sister clinic 45 miles away so we can share our expenses. Well, okay, so who's going to drive the hour and a half back and forth to share our rolls of toilet paper? Or could we just order one case for each clinic and make it easy? Okay. Another thing that happened when we did our budget this year is that my clinic starts with a B. The clinic right before me on the list starts with an A. Somehow, the A clinic, who's only open about 20 hours a week, their budget ended up on top of my 40-hour-a-week budget. And the budget that we submitted is not in the budget. And we're being told by our regional administrator that we need to hold to the budget that they gave us with the misprint on it. So, kind of fun. So I went to a rural health conference about 2 weeks ago. I was all excited to hang out with my other rural people, and it was in Lake Tahoe. Those of you who know anything about the West, Lake Tahoe is within about 35-minute freeway drive from Reno, Nevada, where there's a trauma center, multiple hospitals. It's also very close to Sacramento, California, where there's also multiple hospitals. There's also a hospital in Lake Tahoe and a hospital just down the hill in Carson City, the capital of Nevada, the state capital. And I was talking with them, and they considered themselves rural. And I was like, really? And I started telling my story about it's a 2-hour drive to my clinic from Las Vegas, which means that any of my patients who need to see a specialist have to drive 4 hours round trip for their 15-minute appointment with the cardiologist. And they go, well, we have a cardiologist in Tahoe. I said, yes, you do. It's very interesting. This gentleman, Dr. Michael Wilkes, he's an MD from UC Davis School of Medicine. He was presenting at the conference, and I lifted his slide with his picture on it, but it's very important. He talks about the rural health differences. There's poorer overall health than those in urban dwellers. They don't pay attention to the early signs and symptoms of illness, so they come in later in the disease progression, so they're sicker. And I have had my chief medical officers tell me, your patients are really sick. I'm like, yes, they are, and I'm a nurse practitioner, and I'm taking care of them. Our patients have limited finances, and they lack health insurance. They have higher psychological distress, but they're unwilling to admit this. They have a higher rate of substance abuse. They're reluctant to leave their land or home when they get sick. And they have a higher risk of suicide, particularly the elderly. In the past 2 months, I've had 3 elderly suicides in my town of under 1,000. That may not be statistically very much different than those of you in your urban areas, but I know about it because we don't need the newspaper. So here's a picture of my clinic. When I got there, it had peeling paint in a gravel parking lot. And so part of the innovation of marketing is I want patients to come to my clinic. So I've been the squeaky wheel. My clinic has now been painted. We got the parking lot paved so that people with walkers and wheelchairs can actually get out of their car and get into the clinic. I'm the only practicing doctor in town. There's no dentist, veterinarian, pharmacist, as we discussed. Well, there is a retired pharmacist. There's no optometrist, no physical therapist, no psychiatrist, no psychologist. I'm also one of only 2 RNs in town that I know of. The other RN drives to Vegas to work at the trauma center and also does online QA from her home. We don't have paramedics. We have a basic ambulance service. The next closest advanced cardiac life support provider is at our sister clinic. And the closest besides that is our flight nurse and paramedic because we're a 40-minute helicopter flight away from town, which means it's 80 minutes round trip before the patient gets a higher level of care than me. Since we had our VA lady here before, the closest VA clinic is also 75 miles away. But my veterans say that it can take a month to get an appointment. The local VFW, as I said, just bought their historic church, so that's our other veterans system there in town. So one of the other ways that I marketed was I became very involved in the community very fast. So this is a parade, our local Beatty Days parade, and this is called a Gram. It's a special old fire engine. And my first parade that I was there, they asked me to be the judge for the parade because I was a stranger in town, so I wouldn't be biased, right? So since then, I've now been in a couple of the parades. Because one of the other things that I did to market was I joined one of the local volunteer organizations, the Beatty Volunteer Fire Department. Yes, folks, I'm a rookie firefighter at 48 years old. I've joined the Nye County Technical Rope Rescue Team. I'm a certified technical large animal rescuer. I'm a hazardous material awareness and operations level provider. Spearheaded the local Boy Scouts group to get restarted after 12 years of not being, having a Boy Scout unit. We got this really cool number. It's 777. Great number for Nevada, isn't it? I also became a member of the Nye County LEPC. So what is a LEPC? LEPCs were started with the 9/11 issue, and it's a local emergency planning committee. I really felt that I needed to be on this committee as one of the healthcare providers in the middle of the county. Some people could say middle of the state if you're in Massachusetts, and really felt that we needed to be involved with that. So to give you a little bit more idea of the demographics of the town, you heard how far away Walmart is. Well, guess what? We have a mercantile, just like Little House on the Prairie, that has hardware, dog food, and basically one of each choice. So if you like a variety of your shampoo, you really have to plan your shopping because the mercantile basically just has one type of shampoo. We also have a little store at one of the RV parks, and we have a nut and candy factory. So when I'm talking to people about where I am in Beatty, they go, "I've been there. I went to the nut and candy factory." We're just outside of Death Valley National Park. Basically, we're 4 miles from the park border. We're 8 miles from the California border. So many of my patients actually are employees and visitors to the park. So often we get foreigners that come visit us because they like Death Valley. And so we get patients that don't speak English. So of course we do use an interpretation line. We have the AT&T language line, so we use that. But it can be really tough and really lengthen your appointment when you're doing translations. For any of you who've had to translate when you're giving medical care, that can be tough. And we've had a variety of different languages. We've had Russian, French, German, Spanish, just a variety of Korean languages. So it's very interesting, the mix of patients that I get by being there. But one of the foreigners said something, and I just want to kind of iterate. He said, "Your little village, it is so cute." And we call ourselves a town or a township, and we really hadn't thought of ourselves as a village, but I agree with him. We're kind of a nice village. So when you're in a rural area, you kind of need to play where you stay. One of the reasons why I've joined all these volunteer organizations and I'm really involved is because my husband and children still live in Las Vegas. So I work Monday through Friday, 8 to 5. I work with them in town, stay in an apartment. I drive home on the weekends to be with my kids, unless I'm training for the fire department, the rope rescue team, or something like that. So I usually see my family 3 to 5 days a month. And everybody's like, "That's really hard." And I'm like, yeah, but imagine if I was a military person deployed overseas. I at least see my family. I can call them unlimited. I don't have to worry about long distance or anything like that. And when I put it in that perspective, they go, "Oh, okay, that's not so bad." So I do want to share with you, we read about the nurses before, so I want to share the firefighter's pledge. When I read this, of course, I read it as a firefighter, but then I went back and read it as a nurse, and I think it pertains to nurses also. I promise concern for others, a willingness to help all those in need, courage to face and conquer my fears, courage to share and endure the ordeal of those who need me. I promise strength of heart to bear whatever burdens might be placed upon me. strength of body to deliver safety to all those placed in my care. I promise the wisdom to lead, the compassion to comfort, and the love to serve unselfishly whenever I'm called. And I really thought, that's what we do as nurses. So those of you who are nurses and are looking for something else to do, being a firefighter is right along the same lines. Okay, so to close, I was sitting in the clinic working on my daily documentation list, and we close at 5, but it was 8 p.m. I was still documenting, when I got a phone call from a fellow firefighter. And she said, isn't that cool? We have 16 firefighters, and we have 3 women on our fire department. Can you come over to John Doe's house and help me? I, of course, said sure. And then I said, what? And she goes, well, there's something trapped under his bed. So I get over there, and I'm prepared. I'm thinking, well, it's moving. It must be an animal. So I grab my safety goggles, I grab my leather gloves, and head on over there. And this is what we found under his bed. So I just want to tie this in a little bit. This is sometimes called a civet cat, which it's not. It's a ring-tailed cat, but it's not a cat. It's a member of the raccoon family. And this cute little guy, or gal, we're not sure which, we didn't stop to check, is in a box right now. We got it trapped in a dresser drawer. And on top of it is the storm window from John Doe's house. So I wanted to let you know that this little guy had no glass ceiling. We were able to open the glass and let him run free. So as nurses, I want to remind you that you need to break through the glass ceiling, be your leaders, and get out and make policy changes.
Good morning. That was really great. Thanks. I'm going to go ahead. So I'm going to talk today about the role of the convenient care industry, retail clinics that I've been involved with since 2005. And just a little bit of history, I was part of a startup company that was actually acquired by Walgreens. So I will refer to a few things about Walgreens, but more generally about the industry. And really the incredible role that nursing and nurse practitioners have played in this industry, and that just kind of where I see the future going as far as the retail industry. So people refer to the convenient care industry, retail clinics, so clinics inside of big box chains like Walgreens and CVS and Target, as a disruptive innovation. And I love the sign that's up there, because we opened our first clinic in the state of Kansas, in Kansas City. And the nurse practitioners in Kansas City were so excited. We opened the clinics, and I get a call. My corporate office is in Pennsylvania, and I get a call up in Pennsylvania, and it's a nurse practitioner, and she's like, oh my God, Sandy, I saw my first patient. I'm like, okay, how did it go? And she said it was the best thing since a slice of white bread. And that really was the response from day one, from the consumer, from our patients about this industry. It made sense to them because it was convenient, because it was local, it was in their communities. So I'll talk a little bit here. So 8 years ago, these were the headlines out there, right? The health system is broken, right? Will primary care survive? We can't, we don't have enough primary care providers to take care of all the patients. Same headlines that we see today. Again, nothing that everybody in this room doesn't know, but again, the cost of healthcare continuing to rise, limited access to healthcare in the United States, people using the emergency rooms, for things that are not emergent. But what's interesting about the retail model is that, as these models grow, 75% of all America lives within a 5 to 10 mile radius of a retail clinic, meaning or a retail store, so a Walgreens or a CVS. So again, looking at the facts, right? The facts that we know today, more than 50 million people that are uninsured, 1 in every 8 children that don't have. 70% of Americans say, hey, I can't get an appointment when I need it. How many of us in the room have called our primary care provider and said, hey, I think I have a sinus infection, or I think my son has an ear infection, and you can't be seen when you need to be seen, and that's what America is facing. 30% of Americans, and again, this is really valid with our clinics, we track people who come into the clinics, whether or not they have a primary care physician or a primary care provider that they see routinely. 30 to 40% will say, no, I don't have any relationship, and that's what the literature is finding as well. And then almost half of all emergency rooms, right, that are non-emergent. So currently today, there are about 1,400 clinics in the United States, retail clinics, in about 35 different states. Walgreens has 400 clinics today, I'm proud to say, in 20 different states. When we started this business 8 years ago, really they felt, when people were looking at the industry, that the industry could have anywhere from 3,000 to 5,000 clinics. And if you look at, statements that have been made by some of these bigger companies like Walgreens and CVS, they are all working towards having about 1,500 clinics in the future. So a lot of rapid growth. There's probably been about 20 million, over 20 million patients seen through these clinics to date, and there's greater than 5,000 nurse practitioners who practice in the clinics. So yeah, it's amazing, right? So scope of services, again, really looking at where is the industry going. Scope of services will go from being more of acute self-limited to more of an expanded scope, more into disease prevention, health promotion, and looking at chronic disease management. We've seen hospital systems, and we've been consulted by hospital systems saying, hey, how can I get some clinics out in my community? How can I use these clinics to engage patients to come into the system? So the premise of these clinics were really around three things, right? High quality, convenient, and affordable care. And I'll go into these a little bit more. And when you talk about high quality, I'm happy to say, my co-founders were two businessmen, and I'll tell you a kind of short story, but two businessmen who were looking to start this business. One came out of international travel, one came out of Johnson & Johnson Pharmaceutical. And I met with them when they were interviewing for this position, and they basically sat there and quoted off to me all the Mary Mundinger studies about quality of care and about engagement of nurse practitioners with their patients and how patients were extremely satisfied with nurse practitioners. And the two of them just looked at me and they said, but Sandy, we can't figure out why they're not utilized more effectively and efficiently in the healthcare system. And I was like, me neither, right? So there, it was just this, to me it was amazing to have two businessmen who were reading up about nurse practitioners and who could really see where there was value from our profession of how we could play, be a bigger part of the healthcare system and how we serve. So high quality using nurse practitioners. We do have a few PAs that we use in different states that we practice in, but we're predominantly about 99% nurse practitioner in our company. Using technology, walk-in model where no appointments were necessary for patients who just walk in, be seen, as well as now we have some scheduled appointments. And then really making it affordable. So working to have managed care contracts in every state that we're in. And I'm happy to say we have contracts with all the big players across the United States, as well as local insurance groups in the states that we're in, and then also being affordable for people who are paying cash and services. This gives you just an idea of what clinics look like. How many people in the room have ever been to a retail clinic, whether it's a Take Care or a Minute Clinic? Okay, so a number of people. And I think the other big aha, with me, when we were starting this business, it was really important to me as a professional and as a nurse practitioner to make sure that these clinics looked professional and that they represented, that I would be proud to work in a clinic, as well as my patients who came in would feel like, hey, this is a beautiful place. And I'll tell you that that's the overwhelming response of patients. They walk in and they go, wow, this looks just like my doctor's office. But again, very, very well, with technology driven. So you can't really tell from these pictures, but we have kiosks where patients sign in using technology. We have LCD screens that are up outside the clinics that are transparent for patients with all the cost of services, as well as what insurance plans are accepted, and then really using electronic health records and electronic prescribing. So when the model really started with acute self-limiting types of illnesses. So again, like sore throats and ear infections and sinus infections. And 8 years ago, there was a reason for that. because 8 years ago when we started this business, and I told you the first market we opened was Kansas City, right? So we go into Kansas City and we start hiring nurse practitioners and we open our clinics, and on the news in Kansas City are physicians picketing outside the clinics, okay? And again, a disruptive innovation, a disruptive model, and people were threatened. You know, we were on their turf, we were taking their patients, we were disrupting, quality of care. I don't know how many times I've heard, well, those nurse practitioners are going to miss a brain tumor. I'm like, seriously? So, anyways, but there was a reason, and the reason was we needed to kind of be a little bit under the radar, and we needed to get up and have a limited scope of services. And the reason I tell you this, I was recruiting in Denver, and they have the big primary care conference in Denver, a nurse practitioner conference. And we didn't have any clinics up at this time, and I had my little sign, I had a little picture of what I thought it was going to look like. And all of a sudden, I see this woman walking up to my table, and she's small, white hair, right? And she's walking up, she's got her shoes in her hand, okay? And she's pointing her finger at me, and she's shaking her finger, and she says, I don't know about these clinics. You're limiting the scope of practice of nurse practitioners, and I don't think this is right for nurse practitioners, and we've worked too hard. And I look, and her name tag says, Loretta Ford, keynote speaker. And I thought, oh my God, right? And of course, I didn't know who she was, and I'm thinking, okay. So I'm like, well, let me explain to you what we're doing here and why we've limited our services, but we haven't limited the nurse practitioner's ability, from her scope of using her skill sets. And I said, do you have time? Can we go get a cup of tea? And she looked at me and she said, I'll go, but it's got to be over a glass of wine. And I'm like, okay. So, and I say this because she has been a fabulous supporter of the retail industry, a wonderful mentor to me, and to your point about every word counts. And I would be getting quoted in the newspapers or quoted for different things because of my role within the organization. And she would see something, she'd call me and she'd give me feedback like, hey Sandy, be careful how you say this. When you talk about the nurse practitioner, it's the nurse practitioner role, the nursing profession, not the nurse practitioner profession, So very, very always on the game, as you all know, right? So if you look at the growing range of services, in the middle, the treat was kind of where we started, and we've expanded that as well. Then what we really noticed is we really need to be more in preventative services, started doing lots of immunizations, and then looking for opportunities of things that were gaps in care for patients. So things like the shingle vaccine that was hard to find, Gardasil, and different things. We also are doing some specialty injections in some of our markets for patients who are on chronic asthmatic medications that are used as a third-line therapy. So lots of innovation, but trying to be in the community and meet the needs of the patient. And then we've recently, as a company, have expanded into the management bucket, where now we're doing more chronic disease management as well in our clinics, in coordination with the healthcare communities where the clinics are. So when I think about the nurse practitioners and the nurse practitioners who came on board, and there's a big joke in my company. They say, "Oh, Sandy, you made us drink the Kool-Aid," And really, I would say this of our profession as a whole, of risk takers, right? Of really people being able to see the vision and being able to take a risk and come on board. But what was really important was for them to understand what the premise is of this model, and again, around accessibility, quality, and affordability, and then just really knowing that we were going to be under a microscope, right, for what we were delivering, and were we holding true to those premises, and were we able to have data to document and to be able to publish what was going on. So I'm happy to say, transparency, right, like I said, LCD screens, really being totally transparent to patients on what the costs are, having signs up. Our company actually we post our engagement scores of our patients for every clinic. We post all of our quality scores. They're all out on the web, so patients can see what's going on, as well as wait times and all types of different things. as well as just making sure that we're always focused on making it simple for the patient, right? So streamlining our processes, using e-prescribing, using electronic health records and kiosks, and then always measuring engagement of patients. We use Gallup organization to measure engagement, and Gallup uses a little bit of a different slant on things. They'll tell you, you can be satisfied and you go to a great dinner or you go to a hotel and you say, yeah, that was really nice and it met my needs. Or you can be engaged, where you say, oh my gosh, that was the best restaurant I've ever ate at, or the nicest hotel, the customer service was fabulous, and you go out and you tell a dozen people about that. And so we measure engagement. And what's really interesting is that we are able to measure the engagement of retail clinics across not only other healthcare entities that Gallup measures, but we're also able to measure against the high-end kind of customer service focus like the Four Seasons. And we are in the top 10% of Gallup's database for across all entities, meaning that 3 out of 4 patients are highly engaged with this model of care. And that is so significant because it really speaks to what the consumer wants and what patients want. There's a funny question that's in this Gallup database where it says, I can't imagine my life, I can't imagine a world without a Take Care clinic or a health care clinic in Walgreens, right? And the nurse practitioners hate that question, right? And so you have to explain to them what this question means, but you'll be surprised that patients will definitely score that very high. And I was in a market meeting in Denver, and my daughter at the time was working on her MBA, and she was working as an assistant manager in one of the Walgreens stores. So she was at this meeting, and we were going through this question, and the nurse practitioners were just like, Sandy, this is the stupidest question, and why do we have to have this, right? And I'm like, okay, let me try to explain it. And then all of a sudden, my daughter raises her hand in the back, and she doesn't really speak up, and she said, well, it's kind of like this for me. I couldn't imagine my world without my iPhone. And it was like, all of a sudden, the light went on. That was how people saw the clinic. Like, it made so much sense, and it was useful to them, and they didn't want to lose that. So again, highly engaged patients with the model. Clinical excellence, obviously, like I said, I've been in front of the AMA, the AFP, the Kentucky IG, the Tennessee Medical Board, the Texas Medical Board, let me think who else, right? And again, always with concerns over quality is what, the whole concern is always. And so what we did early on was we put process and procedures in place. I came out of the military, had retired, and we did things like peer reviews. We have our collaborative physicians where we have electronic reviews. We were able to show that we could roll that up to a national level. We could show it at a market level. We could show it at an individual provider level. And what we were constantly doing was, supporting our nurse practitioners with education and giving them the best practices. So everything that we do is evidence-based and driven by evidence-based medicine, but always with the nurse practitioner being able to use her clinical judgment. Our company is very focused on giving them the tools, helping to support them, but not protocol-driven, I guess is the best way to say. Not protocol-driven, but clinical judgment-driven. So again, these are studies. One of the other things I heard a lot was, these clinics will increase cost to the system, right? Which we've been able to prove that by having increased access, 40% of patients who don't have PCPs, patients who are using the emergency room could be seen in convenient care clinics. The patients, obviously 93% report highly on the convenience. And then, like I told you earlier, that people live close to 10-minute drive of a clinic. And that says 30% of the U.S. population. Walgreens would tell you it's 75% of the U.S. population lives within a Walgreens, perimeter of a Walgreens store. This is a study that just showed that if patients were to use an urgent care or an emergency room, the potential savings of $4.4 billion, right? So working with managed care organizations, working with self-employed industry, working to try to get patients to come into the system at a lower cost of care, either through a convenient care clinic or an urgent care. Decreasing costs, again, lots of studies out there showing that the cost for services are about a third. So going to a retail clinic is about a third the cost of going to an urgent care, half the cost of going to a primary care office, and significantly less than an emergency room. And again, some studies that were done in Minnesota showing that if they were able to direct patients, the savings that they would have. And then quality outcomes. We measure, again, for the retail clinic industry, because it's a newer industry, we were measuring things that we were commonly seeing. So HEDIS scores we were measuring for appropriate prescribing and utilization of antibiotics, because of course that was one of the big concerns, obviously, from the AMA and different people, that they felt that the only reason Walgreens or CVS or anybody was utilizing or having these clinics was to drive prescriptions, right? So basically they'd say, well, you know, you hired those nurse practitioners so they could write scripts, and you know, that they would be writing more scripts for patients. So we were able to document appropriate antibiotic prescribing and track all of our prescribing by the nurse practitioners. And obviously studies that have proven that our scores are better than the community for appropriate prescribing, which is, again, is another great hand for nurse practitioners. So a couple of things that I wanted to tell you about my journey. Obviously, my interaction with Loretta, which was fun, and then my two co-founders. So when I was actually hired, so I came out of the military and retired, like I said, in '99. But when I started working with these guys, you know, we were a startup company. We didn't have a name for the company. We were working off of our AOL accounts. For months, I did stuff for them. And my husband said, "Are you ever going to be paid? Do you get a paycheck?" And I said, "Well, not yet, because they don't have funding yet." You know? But it was this kind of like, I want to say blind faith in a lot of ways. And so when we finally did get an office and we finally did get, you know, a name for the company, I came in and my job description was sitting on my desk. And I looked at it, and it said, National Director of Nursing. And I looked and I thought, well, okay, that's kind of interesting. And then I looked and it said, I reported to the Chief Medical Officer. And I thought, right? And she was lovely, the Chief Medical Officer, who was part of the startup company. But I'd come out of the military where there was always a general of the nurse corps, general of the medical corps, you know, and nursing always reported to nursing. So anyways, I called my husband and he said, I said, I have a problem. And he said, Sandy, you need to just sit back and be quiet. Like he's thinking, hey, they're finally paying you and now you're gonna, right? And so I said, well, you know, that's not gonna happen, right? So anyways, I walked in and Hal and Peter are their names, right? And they were sitting and I said, do you have a minute? And they said, sure. And I said, I have a problem. I said, you know, do you understand that nursing is its own profession? And so then I went on to tell them, you know, like, I can't believe that, you know, you have a chief medical officer, a chief marketing officer, a chief IT officer, but you don't have a chief nurse practitioner officer. And they both just looked at me, and Peter says, you know, can you give me 20 minutes? Can you give us 20 minutes? So I'm thinking, oh my God, right? So I thought, okay. So I walked back in my office, I called my husband and said, oh my God, I think I'm getting fired. So anyways, they walked back in, came down and they sat down and they said, Sandy, you are absolutely right. You know, we just didn't recognize it, and here's what we're gonna do. And from that point on, what it really did was put me at the table strategically with all the other officers, and was able to let me design a structure that was all NP managed and led within the organization. And today that's what we have, which is very, very powerful. But again, like I said, put us at the table. There's always a risk, but you have to be at the table. But being able to create shared governance models and nursing leadership. So I am gonna, let me just go quickly. We talked a little bit about CCA, and you guys can read up about it, the Convenient Care Association. But what I want to just close with is that I think we're in a perfect situation. We have the Future of Nursing report, which you all know, about utilization of everybody to their full skills. The National Governor's report, which really comes out and says, hey, states that aren't there, you need to get there. You know, these are just some headlines that have been in the news, you know, where really nurse practitioners are out there now. We're in the Wall Street Journal, we're everywhere. Where 8 years ago, you know, there wasn't a face for nurse practitioners, or it was a limited view of nurse practitioners. And then really what we need to do is be the change agents, right? Really looking at how do we continue to innovate, use technology. And then I'm gonna just end with this, because I used to think my biggest fear was failing at something and not being successful, right? And really our deepest fear is not that we're inadequate, but our deepest fear is that we're more powerful beyond our belief, right? And that if we let our light shine, then we can let the light of others shine and just be very powerful. So thank you very much.
Good morning, everyone. If I seem nervous, it's probably true. And if I'm shaking, it's not nerves, it's because I'm cold. So please bear with me. My name is Carolyn Aoyama. I'm a nurse midwife. My alma mater, I have to say something about my alma mater, the University of Wisconsin, where I got my bachelor's in nursing. At the time when I was a student, which was a long time ago, it seemed to me that I was being inculcated with care for humanity. In other words, kind of the highest expression of nursing was human rights. That's what I took away from my education. And that's what I'm going to talk a little bit about today in terms of Indian Health Service and the U.S. Public Health Service. By the way, this uniform is not a military uniform. It is a U.S. Public Health Service uniform. And I'm proud to say that nurses make up the largest category in the U.S. Public Health Service. Anyway, I diverge here. The goals are simply to tell you a little bit about Indian Health Service and about the practice of advanced practice nursing within the IHS and nursing in general. First of all, I need to tell you what IHS is. It's an agency of the government, HHS, and we provide medical, dental, water, sewer, nursing services to American Indian and Alaska Natives nationwide. The mission is to raise the physical, mental, and spiritual health of American Indian Alaska Natives to the highest possible level. I love this slide because I started out in IHS as a public health nurse a long time ago, driving a Jeep around 650 square miles of desert. And this is a historical photograph from Indian Health Service of a public health nurse driving around her, what, Chevy? I'm not sure. 50s, 55, something like that. So why is the government in the business of providing healthcare services for American Indian Alaska Natives? First of all, the business of the U.S. Public Health Service is really vulnerable populations. That's the business. American Indian Alaska Native people are among the most vulnerable in this country. The foundation for our involvement in healthcare for American Indians is the fact that, oops, I pressed the wrong button. The fact that, oh, go back one. Okay, thanks. There are many treaties that form the foundation of the relationship between the U.S. government and the currently 566 federally recognized tribes. It's a government-to-government relationship from 1787 forward, based on the Constitution. And as I said, numerous treaties, laws, Supreme Court decisions, executive orders, etc., form this relationship. Indian Health Service provides care for about 1.5 million American Indian Alaska Natives across the U.S. This is a slightly old slide, sorry. It's 566 federally recognized tribes in 35 states. The federal government continues to recognize tribes every year. There's a process, and it's not an easy one, but it's a lot of tribes. Some are large, and some are very small. IHS has 12 area offices, something like the regional offices, but we have 12 area offices, 48 hospitals, 270 clinics across 30 states. And no, we don't serve all of the Indians in the whole entire United States. We don't have the budget for that, but we do serve 30 states. I should say here that the Indian Health Service is about half the size that it was in the 80s. And that's because IHS has been basically giving up part of their budget as tribes come in and request either to contract with the government to provide their own health care delivery or to compact, which means every tribe has a number of shares, like shareholders, and the pie is divided by those shares, and tribes can take their shares all the way from the bottom all the way up to headquarters. So in other words, let's say as the Alaska tribes did, they wanted to take over all their health care. That meant that they took over all the hospitals, all the clinics, all the providers, and part of the budget for their area office, the Alaska area office, and for headquarters. So it's considerable. This is where we are. I personally have worked in Alaska and Arizona and New Mexico. And in terms of frontier, I think of frontier in terms of you can't get to the hospital unless you take a plane. That to me is frontier, and it's not a big plane. It's a little 2-engine plane. It's a little putt-putt. So, yes, you can see that we have concentrations of healthcare facilities in Oklahoma, Arizona, New Mexico, California, and then the northern tier of states, but you know, the Dakotas, Minnesota, Wisconsin, Wyoming, etc. So we're all over the place. And I borrowed this slide. We are the definition of frontier, basically. From taking a plane, taking a snow-go, a 4-wheel drive. I personally had to drive a Jeep and often was in all 4-wheel drive in order to get to where I needed to go to on the Navajo reservation. In other words, my families were off the road system. They didn't have water. They didn't have sewer. The average age of the hospitals in IHS is about 50 years of age. This is the Chinle Hospital. It's a relatively new hospital. Chinle is located kind of in the heart of the Navajo reservation. And Chinle, let's see, what's special about Chinle? They have a very strong midwifery practice there. All the babies are delivered by midwives. And it's near Canyon de Chelly, and I highly recommend that to you as a tourist destination. Burden of disease and health disparities. It's not a new story. This is an old story. American Indians, Alaska Natives have high rates of tuberculosis, alcoholism and alcohol-related diseases, diabetes. American Indian youth have the highest rate of suicide of any ethnic group in the United States. They don't live as long, and they have higher rates of death at birth. Again, another iteration of the same thing, except you'll see here some of the issues that we deal with on a constant basis are patients that have many comorbidities, chronic diseases, including alcoholism, diabetes, hypertension, heart disease, and to have that all wrapped up in one. And I know you all are familiar with this. I mean, this is common, but for us, it's very common. In addition, the midwives are dealing with high rates of preeclampsia and HELLP syndrome, severe OB hemorrhage, incredible hemorrhage. And this is Alaska. And this is going to be part travelogue, I guess, too. Yeah, this is the tundra, and this is part of the area where I was. So what do APRNs do? Well, first let me tell you that we have around 2,800 nurses. And APRNs spring out of the practice of nursing. And it's just a fact. We are nurses first. I think that's clear. We have about 500 APRNs, depending. I mean, that's the number of positions that we have. You can see here that the bulk of our APRNs are nurse practitioners, but we have nurse midwives and CRNAs as well. Most of our nurse practitioners are FNPs, but we have psych mental health NPs, psych mental health CNSs, PNPs, adult nurse practitioners, women's health nurse practitioners. What's missing? Emergency nurse practitioners. We need them. We also need acute care nurse practitioners. And if it was up to me, we would have them. We would absolutely have them. However, it's not up to me, even though I'm the senior consultant for advanced practice nursing. All hiring is done at the local level. All these little hospitals have cultures of their own, and they get to advertise for whoever they choose. So. And one of the common complaints I've heard in terms of emergency nurse practitioners is they take too long. And I say to myself, okay, they're taking too long asking this patient who was brought in by their relatives if they have a refrigerator that they can keep their insulin in. Really? They're taking too long. Nurse midwives. We have large midwifery practices in Arizona, New Mexico, Oklahoma, and in Alaska. And we have, I want to say this because we're on the nurse midwifery slide, is that most of our babies are delivered by nurse midwives. Yay. And a shout out for nurse midwifery. In fact, and most of our anesthesia is delivered by CRNAs. Yay. In fact, IHS would be hard-pressed to continue to operate without advanced practice nurses. One of the accomplishments that we've been able to advance is a national scopes of practice. This may be controversial, I don't know, but for us it was essential. IHS, as a federal agency, has specifically regulated the credentials and qualifications required to practice as an IHS APRN. A lot of type, a lot of script here. Basically, this is what the policy states. And except for controlled substances, Indian Health Service has a national scopes of practice, which means for us that we have an easier time credentialing our APRNs and understanding what they're doing, expecting the same thing wherever they're working in IHS. How do we do it? Federal supremacy and preemption. The preemption doctrine derives from the supremacy clause of the Constitution, which states, and I'm reading here, that the Constitution and the laws of the U.S. shall be the supreme law of the land. Anything in the constitutions or laws of any state to the contrary notwithstanding. Therefore, this basically translates that any federal law, even a regulation of a federal agency, trumps any conflicting state law. And this has been upheld in court. And it's helpful to us. It has simplified our credentialing and privileging. It helps us explain ourselves to the rest of the team in terms of what we can do. And it has greatly reduced the complexity of monitoring multiple state licenses at individual sites. This is what Monument Valley looks like, or excuse me, this is what Canyon de Chelly looks like at the bottom. And you can go there and see it for yourselves. It's gorgeous, but you have to watch out for the quicksand. So what is the role of the state boards of nursing vis-a-vis our national scopes? State boards retain the authority to discipline and retain the Schedule II drug authority. We don't have that authority. That resides with the state boards of nursing. We work closely with state boards of nursing, actually. This is a master carver in Alaska, a totem carver. He's Tlingit. Okay, this is what we do. Midwives deliver the babies, CRNAs deliver the anesthesia, and we've had a major push. I was involved in fact, I pioneered establishing the standard of care for sexual assault victims for American Indian Alaska Natives served in Indian Health Service. What did we have before? We had physicians who weren't trained doing these exams and really not wanting to do them because they expected to be gone in a couple of years and they didn't want the bother of coming back to testify. Our nurse practitioner workforce sticks around longer than the physicians, and most are women, and most have a vested personal interest in seeing that American Indian women have the same access to justice that other women have in this country. And that starts with an excellent forensic exam, with DNA collection, et cetera, et cetera, et cetera. So now we are implementing that. That's the latest new development within Indian Health Service, is that we can say that our standard of care meets the national standard for sexual assault victims. We expect all of our sexual assault nurse examiners. Thank you. Yeah, this was my little project when I got there. I was hired by Sandy Haldane, the prior chief nurse, and she basically told me on my third day of work, she said, "Carolyn, I hired you to do women's health and advanced practice registered nursing, and do it, and I'll have your back. Whatever you think needs to be done." And the first thing that came on my desk and the first calls I got were from stakeholder groups of American Indian women who had been working on this issue for many years, but hadn't yet been able to crack the policy at IHS. And so it was a marriage made in heaven, really, because I was all about that. And I think that I'm not alone in IHS or within the U.S. Public Health Service. I think that nurses within IHS, particularly APRNs, are pioneers. They're risk takers. They are there partly for the adventure and partly because transcultural nursing is so interesting and so rewarding. So, this is, again, not Monument Valley. This is Canyon de Chelly, and this is a picture of Spider Rock. Spider Rock, on the top of Spider Rock is Spider Woman. And Spider Woman is a major figure in Navajo, the Navajo creation story. I just want to say this. APRN leadership in IHS is exemplified by, we have a service line manager for women and infant care at the Phoenix Indian Medical Center. She's a midwife. Midwives pioneered prenatal substance abuse treatment within the clinic at a large IHS hospital. An FNP created the very first IHS pain clinic. A psych mental health NP pioneered telehealth and telepsychiatry. This is the Alaska Native Medical Center. And we have a sexual assault policy. We've got a partnership with the Department of Justice, Office on Victims of Crime, and the FBI. And we are doing all kinds of other good things. The chief nurse of IHS has established a nurse residency program so that we can get our DNPs and PhDs. The Alaska Native Medical Center is a magnet hospital, and 5 IHS hospitals are now certified baby-friendly, and we're going for all 12. Thank you.
Thank you to our advanced practice registered nurses who are doing wonderful things in this informative discussion. We probably have time for a half a question, a burning half a question. And the president is here, so I'll let her take over then.
Hi. Oh, dear. I just want to say congratulations. That was excellent. You're definitely transforming care and driving policy. I come from Australia, and I'm leading a student-run clinic of a very similar nature. I would encourage you to help transform nursing education by bringing the new workforce with you. Thank you.
Thank you.
This is working.
Mic on? Chuck?
Hello? Okay. Nancy Valentine, Philadelphia. This is for Sandy Ryan, but really for anyone. And this question does go a bit beyond the scope of this particular presentation, but I noticed that you are using nurse practitioners and physician's assistants somewhat interchangeably, at least in your slide. And I would just be curious, and again, I think it's a topic for a different discussion to really get in depth, if you do see them as interchangeable. Thank you.
Another half a question.
Well, respond to the first, and then this really has to be the last one. So Sandy, do you want to make a quick comment?
Yeah, is this on? Can you guys hear me? Okay. So I would say, you know, in states where physician assistants can practice, where it makes sense, we do use physician assistants. We hold them to the same standards that we hold our nurse practitioners, meaning from our quality reviews and process. I think, you know, again, there's differences, obviously, in education and training and models of where they practice. We have been monitoring quality of care issues within our organization, and right now, for the scope that we're seeing, we really did not have a lot of differences between the PAs and the NPs in the scope that we are currently seeing. I think what's important is, you know, I think obviously we're pretty NP-centric. I obviously have a tendency to want to be all NP-centric, but I think what you have to remember is there's not enough access points and not enough primary care providers. And I think our responsibility is to put people in place who can provide services, and then as leadership to monitor and mentor and grow and groom and put the right process and procedures in place.
Thanks, Sandy. Yes,
Yep.
one last.
I was really pleased to hear in the report of the Indian Health Service the attention to mental health issues that was really woven throughout what you talked about. And I know that in the small clinic in Nevada, you talked about people's reluctance to talk about their psychological issues. And I'm curious, though, about the retail clinic. There was no mention at all of mental health issues, and I'm wondering about your attention to screening really important disorders that need to be identified in primary care.
Yeah.
This will be the last comment, and then we will bring closure, so please respond.
And I would say, you know, initially, right, it was more of an acute self-limited type of model. As we've expanded, not all operators have, as we've expanded, we are starting to see and treat more, you know, mild to moderate depression and different types of things. We're also doing more screening with the elderly, so we're doing things like Medicare wellness exams and what we consider a CEMA exam, which is more of a comprehensive Medicare exam as well. So we are moving in that direction to be able to do some work there, because it is very needed, to your point. Absolutely. Thank you. Yep.
I want to thank these panelists and our coordinator here for really provoking some discussion, and I know it will continue. So those of you who weren't able to come to the microphone, please interact with those that you are wanting to follow up with, and enjoy lunch. There's a wealth of activities. I'm not going to go over them now. Just look in your program, pick a policy dialogue, be active, and we'll see you tonight at the receptions. Thank you.